Welcome everyone to our March seminar this year's series. And today it's our great pleasure to have Dr. Pinar Keskinocak to speak at our seminar. Dr. Keskinocak is a professor at the School of Industrial and System Engineering and the director of the Health and Humanitarian System at Georgia Tech. And her research has focused on applying a variety of the quantitative and analytical methods in many different healthcare topics, including disease modeling, vaccination, organ transplant, hospital operations, disaster responses, just to name a few. She has also worked closely with many governmental and non-governmental organizations, healthcare providers, and translated her research findings into real-world positive impact on the society. I definitely should also mention that Dr. Keskinocak has been very active in serving our academic community. In the past, she has served the president of this Health Application Society, this very same society this seminar series belong to. She has also been the president of the entire Inform Society, has been served as a department editors in many leading journals in our field. All right, so without further ado, let's welcome our speaker. Pinar, please, floor is yours.
So I will talk about some of the work from our team at Georgia Tech on infectious disease modeling. But I know that there are many others in our society, within Inform's community and beyond, who do work on modeling. Just given the time, I'm going to focus on the work from our team, but I would like to acknowledge that there are many others, including some of you here, who do work in this area. And I think there's still a lot of room for us to contribute here. And I also would like to do a little plug-in for our Center for Health and Humanitarian Systems. We have many other projects in other areas related to either health systems or humanitarian systems. You can find information on some of them on our website. So we will talk about infectious diseases today, and there's sadly no shortage of them still. We made lots and lots of progress over the years in keeping these diseases in check, doing vaccinations and other kinds of interventions. But they are still around. So, malaria, for example, affects large areas around the world. You see some of it in the map behind. Cholera is still a big problem in a lot of areas. And of course, we've been dealing with COVID-19. I wish I could say, hey, we dealt with it and we are done with it, but we are not there yet. So it's still with us and might stay with us, become endemic moving forward. So in disease modeling, we try to achieve a couple of different goals. So one is understanding and projecting the disease spread. If we do nothing, what happens? If we do certain things, what happens? How can you evaluate the impact of these interventions? And as we look at the interventions, sometimes you also have to think about resource needs. So for example, the interventions, maybe ideally we would like to do this, but we only have resources to do that. So how do we best allocate those limited resources to get most bang out of the buck, if you will? So we can then use these for resource planning and allocation. And we need to think about all of these decisions geographically, over time, and by subpopulations. So why? Because there could be differences, geographic differences in how the disease spreads and the environment and the underlying conditions. Some of these diseases could be affected by weather patterns. Think about a disease like malaria, for example, where there's definitely some seasonality. And then the kind of interventions we implement or any kind of changes in people's behavior would also impact how the disease spreads geographically and over time. And then, of course, we really care about subpopulations because the underlying conditions in the subpopulations might be different. The kind of access they might or might not have to certain resources might be different. So we want to pay a lot of attention to that to ensure equity and keeping in mind that equal is not always equitable, right? So if you allocate the resources equally or proportionally, you might not get similar outcomes in different subpopulations. So if you care about equitability, you need to keep that in mind. So we think about all of these things and very complex, multiple dimensions, and modeling helps us in evaluating the trade-offs and then making more informed decisions in this context. So at the bottom here, you see, a couple of diseases. I'm going to touch on some of these today, time permitting. Just a quick question. When you look at these, 5, 6 diseases that I listed down there, what kind of similarities or differences do you see when you think about modeling? What similarities or differences we might have to consider as we think about modeling these diseases? Anybody? And I'm not looking for a perfect answer, and maybe not even an answer, maybe even a question. Like, what would you like to know about these diseases if you would like to model them?
Okay, I see someone raise their hands.
Yeah, go ahead, just speak.
Sure, Pinar, this is Elisa Long.
Hi, Elisa.
I think the transmission modes, of course, differ by these diseases.
Yep, transmission modes. We'll touch on those a little bit. How are these diseases transmitted from one person to another? Absolutely. Anything else? Maybe something about the durations. I'll come back to it, but there are some differences, and they would impact how we approach. And for those of you, who might be new to disease modeling, and especially for students, so these are the kinds of things you might want to understand as you approach what kind of model might be appropriate, or what characteristics or factors you might want to capture in the model. Transmission mode being definitely one of them, but also some of the other factors, which we will discuss with a couple of examples. So most of these models have 2 major components. So the first piece is how the disease progresses in an individual. If you contract the disease, what happens in the body? And when I say individual, this individual doesn't have to be a human. It could also be an animal, a host, or a vector. And then the second is the spread of the disease within the population. And again, this doesn't necessarily have to be just among humans or human to human. So it really depends on the type of the disease. So the progression within an individual, let's kind of focus on humans for a moment. And what I'm showing here would actually apply to a wide variety of diseases, but think COVID if it's easier, because it's probably been in your mind recently. So if a person is susceptible to the disease, which means they don't have immunity, and then they get exposed, from there, typically they would go into what we call a pre-symptomatic phase, where maybe they are not showing any indication of the disease. And then from there, if they are lucky, they go to an asymptomatic phase. They are infected, but not showing any symptoms, or not so lucky, go to a symptomatic phase. And then from either of these, hopefully they recover. In some cases, it might require hospitalization, and in some cases, it might actually lead to death. So just a very standard picture that would apply to a wide variety of diseases. But of course, there are differences in terms of how you transition, for example, from the pre-symptomatic to asymptomatic or symptomatic. What are the probabilities for these? How long you might stay in these different stages? And then, any of these transition probabilities, durations, and so on. For a given disease, it might depend on the person, underlying health conditions, age, and so on. But of course, you would see, even bigger differences across different diseases. So this is one of the areas where even if the same structure holds, we would have to estimate these parameters depending on the disease type. And then for the same disease, again, we need to think about the distribution for the population or subpopulation we are trying to model. So in terms of the spread, again, let's think humans for the moment. So most of the spread happens within among people who have close connections to each other, who spend time to each other in close proximity, such as households. And then we also spend time with our, what I call peer groups. For children, this would be school. They go to school, let's say, every day, and then in the same classroom with the same people. For people who go to work, they interact with the same group of people almost daily. So maybe not as close as the kind of physical interaction you have as your household members, but still you are within close proximity of each other and for long periods of time and repeated. So from there, we go to the next level, which is the community, where you interact with people who are not necessarily known to you, but think about going to a grocery store or getting on a subway, where you are with these people for some period of time, not as extended or repeated, but you still are in the same physical space. So that's when we think about the transmission. The chance of transmission is typically higher within the household, than a little bit less within your peer group and a little bit less within the community. So we incorporate some of these information into the models. So depending on the model type, for example, if we are doing an agent-based model where we have an entity, an agent representing an individual in the population, we need to incorporate a lot of data. Think about the population characteristics, the age groups, the household sizes. We talk about households, depending on where you are, the size of the household, as well as the age distribution within the household might be different. Peer groups, think about school, the classroom sizes, depending on the age of the children, and again, where they are located, let's say within a state, the distribution might be different. So there's lots of data that you might need to populate these models depending on the model type. So for agent-based models, typically you need a lot more data and more testing calibration to make sure the model is doing the right thing. So we'll discuss this a little bit more, the model type and depending on the type of question you might be asking. So for the natural history part of the model, we typically rely on the literature from medicine, where they do work to estimate some of these parameters in terms of the duration, the probabilities, and so on. So typically we would pull those parameters from the literature. Okay, so Elisa mentioned the different transmission modes. So COVID, flu, some of the sexually transmitted diseases, human-to-human transmission, and then, but that's not all. Some of the other diseases might have different transmission modes. So, for example, vehicles could play a role in the transmission. Food, water, blood, and so on is what I refer to as vehicles. And then I listed a couple of diseases there, such as cholera and salmonella. So, for example, waterborne, we call sometimes waterborne diseases. These are the types of illnesses that are caused by really small organisms. They could be virus or bacteria. And then a person might ingest some of these, by drinking contaminated water, or by coming in contact with feces if there is no well-established water sanitation hygiene infrastructure. So quite different than what we see, for example, with COVID, cold or flu. So one example here is the cholera, and that's where you see the 5 F's in terms of the things that contribute to the transmission of cholera. And again, here, think about barriers like having safe water, water sanitation, hygiene, just general infrastructure, hand washing. Those are the kinds of things that would actually help prevent the spread. So we are really talking about some of these broader speaking environmental factor. I don't necessarily mean just the natural environment, but the human developed environmental factors in the infrastructure definitely play a role. You may not think about cholera too much in the United States, but it's still pretty significant, affecting many populations around the world. We still might see outbreaks. Sometimes they might come after a natural disaster, such as a major flood or hurricane, just because the systems that we have in place might be affected. And then we might have contaminated water. So it's still a serious problem in many parts of the world. It's treatable, but access to treatment might also not always be available. So there's a reason why there was a picture of a child in the previous slide that I shared. So what we are seeing here is that the mortality of cholera, the adverse outcome, differs significantly by age. So you see at the bottom, the younger children, less than 1. You see tall bars, so meaning that they are much more likely to die. And then as we go to 1 to 4, it gets a little bit better, not a whole lot, a little bit. And then when we move to 5 to 14, you see much shorter bars. And then as we go 15 and above, the bars get even shorter. So each bar represents a different geographic area. So remember, we talked about geographic subpopulations. So here are subpopulations. We are looking by age. We are looking at geographic areas. But we see the same pattern, regardless of where we look at, which geographic area, we see the same pattern in terms of the age vulnerability for younger people. But the magnitude of this changes depending on where you are. So these are some of the things that we pay attention to. So here we are looking at a pretty large area on this map. And you might think, oh, you know, these things only matter in these large areas, but actually that's not true. If you look at a much smaller geographic area, which could be a country, a state, you might still see significant differences geographically within that area, even though we are not talking about a whole continent here, we are talking about a smaller area, but you can still see significant differences in environmental or risk factors. So for example, depending on the water sources, infrastructure, and so on, you see that the risk is quite different. And in many of these pictures, typically, if you have a darker color or if it's a red, that's worse. So that's what we are seeing here. Some areas here in the middle have much higher risk or attack rate of cholera. Okay, so let's go back to what I discussed earlier. I mentioned that some of these models could be used to inform decisions about resource allocation. How do we allocate limited resources to achieve certain outcomes, certain objectives? There could be multiple objectives, and then how we allocate might depend on those, but sometimes the objectives might also be aligned. So for the cholera case, we developed a mathematical model to allocate the limited amount of oral cholera vaccine by age group geographically over time. And the goal, the objective, the model really works either way. You could try to minimize the number of cases or maximize the number of cases avoided. That's what I'm showing on this graph. But you could also look at the number of deaths avoided thanks to the allocation of this vaccine. So the vaccine is effective for up to 5 years, unlike many other childhood vaccines that might protect you for a lifetime. This one does not. It's only approved for children older than 1 year. You cannot give it to really young children. And the protective power of this vaccine actually dissipates or wanes over time. So you might be at the top of the protection a couple of weeks after you get the vaccine, but then it slowly goes down. So the model that we have, I'm not showing it, it's an integer programming model. It actually tracks these populations over time. So if you gave the vaccine to a group today, you know that they are going to be protected, but the protection is going to get less and less over time. Children are going to move from one age group to another age group over time, depending on the time frame that you are looking at. So two approaches that have been used typically in practice are allocating this vaccine by age, saying that younger kids are more vulnerable. Let's prioritize them, and then we will go to older age groups only if we have time or if we have extra resources. And then the other approach has been, let's focus on the regions or areas where we have the highest risk, and then we will go to other areas only if we have time. So the optimization model looks at a combination, and it doesn't necessarily have to be always the highest risk, highest in terms of age or geography, but basically say, you know, looking into the future, what would be kind of the best combination in each time period, how much to allocate in each time period to different regions. So here you see just a summary of these results for these two approaches that are typically used in practice, and then the optimization approach. It's a simple model, nothing very complicated there. And you can see at the top is the orange graph is if you use this optimization approach and then you really achieve more in terms of the cases avoided. The other two are not too bad, especially if you focus on the age groups primarily. You still get pretty good results, not as good. And the lines look pretty close here to each other, so we might think, oh yeah, maybe it's not worth going with the optimization approach. But if you kind of drill down a little bit, there's actually a big difference in terms of the number of cases avoided when you compare those lines. So, and at this particular level of supply availability, we could actually avoid around 400,000 or more cases. And clearly, even if this was just 400, not 400,000, that would still be important because every case avoided is really important for us. So there's definitely opportunity for using these kinds of models in resource allocation to get the most bang out of the buck for them. So another example is or transmission pathways through vectors or animals. I provided two examples here from our team's work. So malaria is caused by a parasite. It's transmitted, as you see from this picture, it's transmitted from an infected mosquito to a human, and then from this infected human to another mosquito who gets infected by biting this human. So there is no direct transmission between humans. There is no direct transmission between mosquitoes, but you kind of need both for this transmission to happen. So it gets a little bit more complicated when we look at diseases like this, because now we have to track not just the human population, but also the vector population. In this particular example, it's the mosquitoes. So now, think about the agent-based model I was explaining before. You have agents for humans. Now you might have agents for mosquitoes. You kind of need to think about their birth rate, death rate, infection, what are the chances of them reaching a human, and so on and so forth. And their obviously cycle, birth rate, so on is much shorter. But we kind of track these separately, and then we also incorporate the interactions between them into the model. So here's when I want to go back to what I said earlier, the geographically over time discussion we had before. The environmental and other risk factors play a big role here. So for example, depending on the temperature, rainfall, the risk factors change significantly, right? So the mosquitoes breeding, the population growing versus shrinking, depending on the temperature and other factors makes a big difference, as well as the human behaviors. So these are the kinds of things that we need to incorporate into the model. So guinea worm is also very complicated. So this is a disease that was almost eradicated, but it's not, and it's an infection caused by drinking basically unsafe water, unclean water. There might be these small organisms called water fleas in the water, and they may have ingested the larvae, the guinea worm larvae. So then when a human drinks that water, then there's some activity that happens in the digestion system. These these organisms mate, and then the human worm grows like pretty big, 2 to 3 feet, and then after about a year, it's released from the body, typically through the legs, literally like making their way out of the leg. Very painful. And when this happens to humans or animals, animals can also get infected, which is actually one of the big issues with guinea worm right now, because it's so painful. They typically would go to a water source nearby, a pond, a lake, put their leg into the water and then try to release the pain. And that's when the worm comes out and then releases the larvae into the water, and then the whole cycle begins again. Now, there are many complications about the guinea worm disease, which actually make modeling very important. So the life cycle is very long, about a year, which is very different from some of the other diseases that we have discussed as examples today. So if you try to implement an intervention, you would need to wait about a year to see how it worked. And that's really not ideal, right? As you all can imagine. So that's where I think modeling is really, really helpful. And then the other complications here include the fact that we don't have a test for guinea worm at the moment, and we do not have a treatment either. So basically the disease has to take its course, but it's really very, very complicated, very painful. So that's also where we have to think about some other interventions. So with the guinea worm disease, as I mentioned, there's been a huge progress in reducing the number of cases from millions to like dozens. And there was big hope that this disease would be eradicated. Carter Center is a non-governmental organization that has been collaborating with WHO and other partners, taking the lead in eradicating the guinea worm disease. And they were really hoping that this would happen while President Jimmy Carter is still alive. But unfortunately, there's been a significant increase in the number of cases in dogs. While the human cases remain very small, there are very, very large number of dogs infected right now. And then in these areas, oftentimes, the dogs and humans might share the same water sources. So as long as the disease is still circulating in animals, in addition, they found them in baboons and cats and other animals, you really cannot claim any kind of eradication or hope any kind of eradication. So we've been collaborating with the Carter Center on modeling and looking at interventions, specifically two types of interventions. So one of them is tethering of dogs, so that to prevent them from going to the water sources. And the other one is a bait treatment of water, which basically helps reduce the infectivity of the water source. So we developed an agent-based model for this, incorporating some of these environmental factors which impact the infectivity in the water source. And then these two interventions we looked at, and then we can actually adjust some of these factors over time. So our first paper on this focused specifically on the modeling aspect. Then we have a second one which is on evaluating the interventions, and then our current work actually focuses on they call it a target product profile. If we were to develop a test for guinea worm, and there is interest in developing a test, what should be the specific characteristics of this test? What do we want in this test as minimum requirements? So this TPP target profile, product profile is something that WHO develops with others, including some funding agencies. So they want to identify what do we need in this kind of test. So one of the interesting things that came out of this effort is that for many other diseases, when we think about a test, there is typically a treatment available. So when you test someone and they test positive, you might give them a treatment. So in this particular case, there is no treatment, and I talked about the long life cycle. So the isolation could be, if a dog tests positive, you tether this dog until a worm is released. But if the test result came, let's say, 8 to 9 months before the release of the worm, it's very difficult to expect that people will actually consistently tether their dog for 8 to 9 months until the worm emergence. Also interesting about how do we do the testing? Do you just go randomly sample some percentage of the dogs for testing? Do you track them and say, we tested them in this month and maybe we test a different cohort in next month? So those are the kinds of things that when it comes to implementation, make a big difference, but that have not been traditionally incorporated into these target profile, target product profiling kind of approach. So hopefully these examples give you a bit of an idea about the modeling approaches and the kinds of questions you might be able to answer with these models depending on the type of the disease. So I'm going to pause here and see if there are any questions, comments, because the rest of the webinar, I want to talk a little bit about COVID, which you probably are tired of it, but there's still more to be done there. Let's see, do we have any questions, any comments from the audience at this point?
Okay, just a quick comment here. I think earlier I accidentally disabled the chat. So some of you are trying to send it in the text in the chat. Now it's open, so feel free to ask any questions there.
Okay. Or
yeah,
just speak up. That's also fine.
Yes.
I see the chat now. Yeah.
And I think there are two earlier questions when we're discussing what are the features or considerations you want to have when dealing with the different diseases. So we do have two comments. One is from Franklin. For surgery, how to manage patients with COVID-19 positive and risk to other remains unclear. So Pinar, can you see the?
Yeah, I see it.
Yeah.
I see it. And thank you for joining. Thank you. So for surgery, how to manage patients COVID-19 positive and risk to others remains unclear. Yeah, I think this is probably a resource allocation type question, right? So we have limited resources. How do we allocate those resources across different patients? And I think maybe by now there is a better understanding in the medical community, but early on it was very difficult, especially given the limitations in the PPE availability. And then some hospitals, I think, try to group COVID patients into the same area, and then would try to avoid the same healthcare professionals going between these different patients who do have COVID and who don't have COVID. So they said, instead of doing that, we will just separate, and then maybe some of the medical professionals will only work with this group of patients, and then others will work with this other group of patients. So we don't have to keep changing. So that had to initially, I think, incorporate a change in the workflow, because that's not how they were necessarily operating before. But if you have comments on this, Dr. Dexter, please speak up. Would love to hear your thoughts, since you have much more knowledge and experience on the medical side. How are you?
Hi, I'm fine, thank you very much. At least at the University of Iowa, there are occasionally patients with influenza, but you have over a period of, let's say, 6 months, the idea that a patient would post-operatively, if they're an inpatient, develop influenza might be maybe 1 patient out of 10,000. Very uncommon. In contrast, whether you're testing patients for COVID or not, whether they're inpatient or not, the development of COVID-19 is vastly greater, maybe 1% to 2% of patients. So in other words, having surgery is a risk factor for developing COVID-19. Whether you have a lot of family members who may be close to you, which otherwise wouldn't, whether it's healthcare workers. Mm-hmm. And so separate from the issue in terms of preoperative testing, the issue would be is how does the dynamics of influenza, even if the prevalence in the community is relatively similar, differ from COVID-19, so that there's so much more post-operative development of COVID-19 as compared to influenza.
Yeah, that's very interesting. Yeah, I mean, I don't know, you probably have a better sense as to what the reasons might be.
No, I don't. I have data, but what is it in terms of now that the it's been quite a while where people are, vaccinated, where the use of preoperative testing is really going away. I would have thought that by now, the situation would be different. But it seems to be that there is an inherent difference between how influenza spreads, whether it be in the hospital setting. Presumably, just like healthcare workers all virtually all get an influenza vaccination annually. But nevertheless, the idea that influenza is a substantive problem in a perioperative period, it's just not so. It's not a big problem. COVID-19 is different.
Yeah.
Yeah.
So somehow there is a higher risk of acquiring COVID-19 after an operation compared to the risk of acquiring influenza is
yes,
seems to be the case.
Yeah, that is the situation.
And it's not clear what may be contributing to that. So that's very interesting. So I think for all of us who are on the call here, that's a very interesting research question. Some of us may follow up with you on this, if that's okay, after the webinar. See if there might be an opportunity to collaborate there. And I see another question here which says similarity in terms of the examples that we shared. All of the diseases need resources and are dynamic by nature that may evolve over time. That's correct, and that's where we try to use these modeling approaches to capture some of those dynamics as well as the resource needs. Okay, so are there any other?
I think that's the question we have for
okay.
now. Yes.
If anybody else would like to chime in anytime, just please feel free to interrupt. So I'm going to talk a little bit about our team's work on COVID-19 modeling. And I listed, a number of collaborators here, as well as funding agencies. I may have left out some of the collaborators, so I apologize in advance, but our research team has collaborated with a large group of people within and outside of academia on different aspects of this. So I will give you a little bit of snippets from these different things that we have done, and happy to follow up offline. And Kishi, just to make sure, I should wrap up maybe around 1:50 and leave 5 minutes or so for questions.
Sounds good.
Right? Okay. All right. So we'll go through this real fast. But let's start with what we have done, a bit following the COVID timeline, what our team has done. So our initial focus was on modeling and then evaluating some of these non-pharmaceutical interventions, because we didn't have vaccines or testing or known treatments at the very beginning. So the focus was on non-pharmaceutical interventions. How do we evaluate the impact of these in the early days? So that's kind of what the request that we got from the Department of Public Health and the Department of Education in Georgia. So I live in Georgia, so a lot of the collaborations we did initially were within the state. So we developed a COVID model, an agent-based model, following the big picture that I've described earlier. And one of the reasons why we were able to develop this model relatively quickly is because we did have some agent-based models that we had developed a while ago for pandemic flu. And even though they are different diseases, there are some characteristics that are similar from a modeling perspective. So we were able to build on that, but then of course make a little adjustments in terms of parameters and so on. So for COVID. So in terms of the population dynamics, remember one of the big components of the model is how do we capture these interactions within the population. So we looked at in addition to school closures and shelter in place, we also looked at a behavioral component called voluntary quarantine, which basically means that if a person or anybody in their household have symptoms, with some probability, not perfect all the time, they withdraw from interacting with other people. So that's what we call voluntary quarantine. And this was important in the early days because, again, we didn't have tests. So symptoms, cold flu-like symptoms, were one of the good indicators that something might be going on. And then in that case, even if someone in the household does not have symptoms, but somebody else does, the person without symptoms could still have the disease. So the recommendation was just kind of stay away from other people if something is going on in your household. So with any of these interventions, whether it's shelter in place, where the state basically recommended everybody just stay away from interactions for however many weeks, or voluntary quarantine, there are different levels of compliance depending on people's personal constraints and or what they perceive as the risk might be in the population. School closure was probably one that people had to follow. They had no choice, but they may have looked at other alternatives in that case. Not sure, but that was the one that we know for sure was implemented because the schools were closed for those periods of time. So the questions that we looked at ahead of time before these decisions were made. So this shelter in place, for how long, does it make sense to do the shelter in place? The state was thinking 3 weeks, 4 weeks, 5 weeks, 6 weeks or longer, what's the benefit? And then we also looked at the impact of compliance with this voluntary quarantine type recommendation. And even within the shelter in place, we didn't assume that everybody was going to do it for sure, but we looked at different levels of shelter in place. Just to give an idea to the state very, very early on, how the combinations of these interactions might actually impact the spread of COVID while we still knew very little about the disease. So when you run these disease models, typically these are the kinds of pictures that you get. So you have the time in the x-axis, and on the y-axis, you have your measure of interest. So here I'm looking at the daily new cases over time. And typically, if you do nothing, you would, if you do nothing, you would have this kind of bell-shaped curve. It starts slow, it picks up, and then slowly it dies down. But when you do interventions, of course, the picture changes significantly. So one of the observations that's kind of obvious now to us at this point in time, but maybe it wasn't that obvious at that time to the decision makers, is if you do nothing, you really, really get very, very high number of infections in a very short period of time. And it was very clear that there was no way for the healthcare system to deal with those kinds of numbers. Then school closures, we were able to see that school closures would help. They would put the numbers down a little bit, but really they would still be very, very high to enable any kind of medical response. So we really had to think about some other interventions. So that was kind of the motivation by showing them the first picture. Just closing school is not going to do it. You really need to do some other things. And then we looked at these other interventions like the shelter in place duration. So we found that shelter in place helps. It really pushes things forward a little bit in terms of the peak time and so on. But you lift it, and if people go back to life as usual, you are really more or less kind of back to square one. You put brakes on it, but you didn't really have a big impact. But then when you combine the shelter in place for a limited duration along with voluntary quarantine, then you can really have a deeper impact, and it gives you a lot more time to prepare by pushing the peak forward in time as well as pushing it down in terms of the magnitude. So those are the initial feedback that we shared with the decision makers. So they were also interested in resource estimation. So if we under any of these different scenarios, how many COVID patients could we see potentially requiring a hospital bed, an ICU bed, or a ventilator? So we came up with these estimates, and then we basically found that in some regions, so Georgia is divided into regions of coordinating hospitals. In some regions, even if you were only seeing COVID patients and nobody else, you would still be tight in terms of your resources. So those were kind of like red flags. We really need to pay attention to these areas, because obviously there are other, diseases, other reasons why people come to a hospital, and under some scenarios, some reasonable scenarios, there wouldn't be enough resources to handle even just COVID patients. So that kind of gave a little bit of heads up to the state decision makers. So over time, we modified these models to incorporate, for example, testing, vaccines, and other kinds of things, as well as behavioral changes such as people might be interacting more, utilizing cell phone data, for example, and then we adjusted some of the parameters as well as the behavioral components in the model. So schools, there's been a lot of debate about schools, the impact on children's learning. Does it really do any good in terms of like keeping the infections in check? So we looked at some scenarios that were suggested by Georgia Department of Education. For example, what if only children under 10 years old go in person and then other children do remote schooling? What if we do an alternating day scenario? Maybe students are divided into two cohorts. One cohort goes on Monday, Wednesday, the other cohort goes on Tuesday, Thursday, and then Friday maybe is a remote day for everybody. How would these different scenarios impact the disease spread within the community? So we evaluated several of these scenarios and shared the results with them. So the alternating day scenario actually performed reasonably well because you are completely separating the cohorts and you are having smaller groups within the school. And the younger children only, was impactful, but maybe not that practical because you would still have many of these other children out of school. So we shared some of these, and then different school districts followed some of these approaches depending on what they were able to afford. For example, those schools who had more resources to incorporate air filters or other kinds of things prefer to go back earlier or implement alternating schedules. Schools with less resources who didn't think they would be able to implement these safely actually remained closed. And my kids' school was in that group, so they were actually out of school for pretty much the entire school year. Another discussion that we heard quite a bit was the people are staying home because of these interventions or because there's somebody in their household who is sick. They need to take care of that person, or they need to take care of their kids who are not going to school. So what's the impact on that on society? So we couldn't put a dollar value on this, which probably some other research teams have done. As a proxy, we use the homebound days. How many homebound days do we incur, depending on the type of intervention or intervention combination that we use? So very, very briefly, what we found is that incorporating this voluntary quarantine intervention that I mentioned as much as possible actually has a very big positive impact. Remember that the duration of voluntary quarantine is relatively short. You do this quarantine only as long as there are symptoms in your household. It's not like for 4 weeks or 6 months or whatever. It's only for that duration, and that's more implementable and reduces the number of homebound days, but still has a pretty big impact on the spread. And of course, if you combine that with testing, you would get even better results. So the results that I shared so far on COVID were all using the agent-based model that I described earlier, because we were really looking at these interventions at the household level and the impact, in different geographic areas. But you don't always need such a very complicated and detailed model to answer certain questions. So we also did some research where we used what I would call these extended SIR models, where we track the cohorts of populations, but not necessarily at that individual level. So some of the other examples that I have here, I'm not going to go into detail in the interest of time, but were done using that different modeling approach. And here we would really take these basic SEIR models and extend them in a way to capture some of these characteristics in the spread or transmission to help us answer the specific question. So for example, one question early on when we had very, very limited availability of vaccine was, is there a benefit for doing some sort of serology testing, thinking that people who may already have had COVID and recovered might have some level of immunity at that point, compared to people who have not been, exposed to COVID before, so they have a higher risk. So should we maybe prioritize those people over the people who already have some level of immunity? So again, this would be valid for a time period or a location where you have a limited amount of vaccine and you are trying to prioritize until you try to bring up your vaccine level to a higher point. And the models basically capture some of these pieces. So for example, you might say somebody may have had COVID and recovered, and if we tested them, we would know their current state. If we didn't test them, we don't. So we might still give them a vaccine, even though they already have some level of immunity. So depending on who we test, how many people we test, you are going to have different number of people in these different subgroups. And then your vaccine allocation is then going to be impacted depending on the knowledge that you have. I'm going to skip quickly over these. Another question we looked at was the trade-off between vaccine efficacy and reach using a different model. If you have some vaccines which maybe are not highly efficacious but easier to distribute versus another vaccine that has high efficacy but logistically speaking harder to distribute, more expensive, limited quantity, how do you use a combination of these different types of vaccines to achieve better results at the population level? And then finally, the last example I have here is the impact of testing and isolation depending on compliance. There's been a lot of emphasis on testing within college campuses, within the population, testing. But I think the piece that we didn't always capture very well was what happens when somebody tests positive, right? So unless that person isolates themselves for a certain amount of time, simply testing and then just going business as usual is not really going to do much. So in that next piece of work, we looked at the trade-off between 4 things. When does testing become available, depending on where we are in the disease timeline? At what capacity does it become available and the capacity ramp up over time? Who are we testing? What percentage of the population are we testing? And then compliance with isolation. So all of these factors affect how much benefit you get from testing at the population level. And we evaluated some of those trade-offs in that piece of research using an extended SIR model. But I'm gonna stop here and just see if there might be any questions. I hope this gives an idea about the kinds of things you can do in the infectious disease space using modeling. I'm happy to follow up with anyone offline if there is interest. But let me see if there are any questions or comments from the audience.
All right, so let's thank our speaker and feel free to type your questions or just unmute yourself to ask any questions if you have. Well, waiting for the question comes in. I'll start with one. So this is very interesting, especially the part about resource allocation and prioritization. You show the examples about prioritizing based on age, prioritizing based on the region. So I always had a question about the contention between prioritization and the equitable results, equity, right? So if you prioritize, you're probably gonna focus on a particular group, but then you may lose the equity. And there seems to be I wouldn't call it a conflict, but it's still something like not really lined up. Sometimes when I work on the cost effectiveness analysis or you have limited resources, there are always people asking, okay, how about the other groups? You basically compromise the other groups for the sake of this group. So always get into that kind of arguments. I just wondering what you think about those, this and how you would typically explain or discuss that.
Yeah, that's a great question, and I don't think there's a very straightforward answer. But what I'm going to say in the 1 or 2 minutes we have is, so we sometimes think of fairness or equity or equitability as having equal or proportional opportunities or resources for groups, right? So one simple example of that is think of vaccine allocation, how it's been done historically. You kind of have a pile, and then you look at the different areas, and then you distribute it proportional to population to those different areas.
Right.
And then within those areas, it may be again distributed proportional to population. So it looks really fair and reasonable. However, there are multiple factors, right? So first of all, those populations to begin with might not have similar risks in terms of contracting the disease or developing adverse outcomes.
Right.
And second, when they do, their access to treatment might not be the same. So when we do this proportional allocation and then look at outcomes, the outcomes will probably look very, very inequitable. You might have much higher rates of infection, hospitalization, or death in certain groups compared to others, even if all of the distribution that we made actually made it to people. So that's, I think, one thing to consider. So are we thinking about equitability or balance in the allocation, or are we thinking about equitability or balance in the outcomes?
Outcome.
They
Yes.
don't always align.
Yes. Yes.
So if we had a magic wand, we would make them align, but they don't always align. So then maybe, the reality is going to be probably somewhere in between. Because if you say, I only care about equitability of outcomes, then your allocation might look very inequitable, and then that may raise some red flags. So you probably find something in between where, you are balancing the goals. Yeah.
Thanks. All right. So earlier I noticed that Ali was raising the hand. Do you want to talk about it? Yes.
Yeah,
Go ahead. Unmute yourself. Yes.
Hello, can you hear me?
Yes.
Yes.
Thank you for an amazing presentation. I was gonna ask, World Health Organization defines like a vaccine hesitancy as the main barrier to herd immunization. And how do you think vaccine hesitancy should be modeled in vaccine resource allocation problems? And do you think should it be modeled, or do you think would it create some equity problems? Thank you.
Yeah, that's a great question. So I don't know specifically like how you model it. So in the agent-based model, it could be, and that's actually what we have done in one of our earlier work, not COVID, but just general looking at flu vaccine. You might have different uptake rates in different regions or subpopulations, and you can incorporate that into the model. So when you, let's say, push proportional to population, but the uptake rate might not be the same. So what might happen is that in some areas, the vaccine is consumed very quickly, and then maybe in other areas, it's still sitting there in the inventory because people are just not interested. And then if you keep pushing, as new vaccine capacity becomes available, you keep pushing proportional to population, you will see again, some areas quickly utilize, and then it keeps piling up in other areas. So, first and foremost, you need visibility, I would say, from a data collection perspective. If capacity or availability is not an issue, if access is not an issue, if people are still not getting vaccinated, you want to know about that, right? So, and then we had a lot of challenges with this kind of data collection earlier in COVID. We didn't know where the vaccine was, how much is sitting in different areas. We didn't know if people are not getting vaccinated, is it because they don't want it, or is it because they can't get to it, because they don't know where to find the vaccine? So we had lots of question marks, and we didn't have very good data collection. So I would say, first and foremost, I think it's important to have this information. And then if you find out that there are some areas where, there is no barriers to access, there is availability, people are still not getting vaccinated, maybe that's where you focus your efforts in education and outreach versus trying to send more or trying to fix access, right? Because if you don't know, then you might say, well, maybe it's an access issue, let's try to fix that, but maybe that's not the real issue. So I would say, really, if anything, what COVID told us is we need much more effort and careful thinking about how we create visibility by better data collection.
All right.
I hope that at
Thanks.
least partly answers the question.
Yeah, thank you so much.
All right, we have one more question, and for the sake of time, let's wrap up that last question asked by Ali from the Q&A, something along the line of the financial burden. So Pinar, you should be able to see the question as well. So basically he is asking, financial burden is the main issue of the disease control. Generally, the more budget you assign, the more effective intervention will be. How would you estimate the budget each scenario need?
Yeah, that's a great question. And that's why, when I was talking about the resource estimation, whether it's hospital beds, ICU beds, or when I talked about the homebound days, we kind of like carefully did not go into the dollar values because they are so difficult. It's not linear, the cost, right? So there are some economies of scale, but then sometimes you really need to make a bigger investment to go to the next level of capacity level. So I don't have a very, very clear answer. I mean, intuitively, you would get some level of diminishing returns, but it might also be an S-shaped curve depending on where you are. Maybe initially you are not getting much benefit from an intervention. It only becomes beneficial after you exceed a certain level, and then maybe you are reaching diminishing returns. So I would say it really depends on the specific application and not very straightforward. Sorry, I'm not answering the question, but I'm just, sharing some insights.
All right. All right, thanks everyone for staying a little bit over time. And well, this is excellent talk and really insightful. And let's thank our speaker again. And Pinar, thank you very much to speak at our
Thanks again
seminar.
for participating. Really appreciate it. Thank you.
Yes. All right. So then take care, everyone. So we'll hope to see everyone next month. Thank you.
Thank you.